Good morning, friends. In today's lecture, we are going to learn about the drugs affecting the coagulation, and we will learn in two parts. Today is the part 1. So, here is the summary what we are going to learn about today. We are going to learn about the coagulants, and in the coagulants, there are various drugs which include fresh frozen plasma, vitamin K, fibrinogen, desmopressin, and ethamycin. We are going to learn only about the important out of this. And in the anticoagulant, we are going to learn about the parenteral and oral anticoagulant. In next lecture, we will learn about antiplatelet and fibrinolytic drugs. So these are the things we are going to cover. So let's directly go to the lecture. First is coagulants. Coagulants means the drug which helps in coagulation. The drug which helps in coagulation. So when do we need the coagulation? We need coagulation when there is bleeding is going on. And why bleeding is going on? Because there is deficiency of either platelet or clotting factor, or maybe due to specific deficiency of the factors, like in case of hemophilia there is hemophilic factor deficiency. And so there are many such diseases, genetic disorder, in which some particular factor may be deficient and it may be leading to the bleeding. So most common and most preferred way is giving fresh frozen plasma. Fresh frozen plasma provides all the factors, and it can be given in emergency and it has immediate effect. So giving fresh frozen plasma is common approach. If the fresh frozen plasma is not available, a blood transfusion can also be given. It will also provide with all the required factors and everything. But the problem is it will require in a very large amount. So there could be a volume overload. And apart from that, there could be problem with the transfusion related reaction, like RH incapability, or transmission of infection from one person to another person can occur. So these are the problems. But fresh frozen plasma is the best therapy when there is a deficit of factor. Other than fresh frozen plasma, a particular factor can also be given, a pooled concentration of that particular factor, like hemophilic factor or any other factor which is deficient can be given. They are costly but require less amount, and chances of reaction are even less than giving plasma. So that was the first coagulant, fresh frozen plasma. Then second, vitamin K. About the vitamin K, you must have learned in the physiology. Let's see briefly. So vitamin K is of two sources, natural source from the diet, as well as it is generated by intestinal flora. The gut flora can also generate the vitamin K. So what vitamin K? The phytonadione K1, it is derived from the plant source or vegetable source we get from the food. The minaquinone is something which is synthesized by gut flora, and naturally it is produced inside the body, and we do not need to take it. Whereas K3 is synthetic vitamin K2. Phytonadione is fat soluble, whereas minaquinone and K3 both are water soluble and can be rapidly absorbed from either oral or a parenteral route. Now, sometimes vitamin K deficiency can occur. Why it occurs? It is rare because mostly it is synthesized from the gut flora, so it is not required. But when the gut flora is damaged or it is not present, a vitamin K deficiency can occur. So when the gut flora is deficient, well, in the premature newborn or newborn, that can be there because the gut flora has yet not developed. So in them, a K deficiency can occur, which can lead to bleeding. In the case of antibiotic therapy, broad spectrum antibiotic sometimes damage the gut flora and can also lead to vitamin K deficiency. So in that case, we have to provide vitamin K from the outside. Now, apart from that, vitamin K is also a very important factor in the synthesis and activation of many coagulation factors. So there are some drugs which we are going to see in the next part of the lecture. That drugs which interfere with the vitamin K deficient dependent synthesis of the coagulation factor, like warfarin. The oral anticoagulant drug warfarin, its main mechanism is by interfering with the vitamin K dependent synthesis of coagulation factor. It is a competitive inhibitor. So in that case, if there is overdose of warfarin, treatment can be done by giving a vitamin K. So vitamin K is useful in such a condition. So bleeding due to overdose of warfarin or newborn and premature, vitamin K is required. Now, but K2 or K3 should be avoided in the newborn. Reason is simple, because it can replace the bilirubin and can produce hyperbilirubinemia and kernicterus. So it should not be used in newborn. Apart from that, in the G6PD deficiency patient, uh, in them also it can lead to hemolysis and can produce oxidative stress. So in them also it should be avoided. Otherwise, they are water soluble and can be given easily. Now coming to the anticoagulant. We have seen coagulants, fresh frozen plasma and vitamin K. Apart from that, fibrin can be given, or gelatin form which is available can be given at the local site, which helps in stopping the bleeding. And in case of epistaxis and that type of bleeding, adrenaline and tide pressure are also useful. Now talking about the anticoagulants. Before going to anticoagulants, we should understand how coagulation occurs. So coagulation has a four phase. There is a first, there occurs a vasoconstriction. Second, there occurs once the after vasoconstriction, if the bleeding is going on, suppose this is the vessel, here is the problem and bleeding is going on. So first vessel will contract, so bleeding decreases, blood flow decreases, the bleeding decreases, the size of the hole becomes smaller. Second thing, there occurs a attachment of platelets. There occurs attachment of platelet, which is called platelet phase. After the platelet has attached, it is followed by formation of fibrin meshwork. Which is called a fibrin phase. It is also primary and secondary. So initially it is still immature, can be easily laced. In the secondary phase it becomes mature. So after all this, again a repair process occurs and it seals, the epithelium is laid down again and it seals the vessel hole. So now vessel hole has been sealed. This thrombus is doing nothing, but it is just producing a block inside the vessel. It is just blocking the pathway. So it is followed by fourth phase, which is called fibrinolytic phase. It is called fibrinolysis or thrombolysis. So it is followed by fibrinolysis or thrombolysis. So now again the pathway is re-established and flow is re-established. So this is how uh, four phases of the uh, thrombus formation: vasoconstriction, platelet aggregation, fibrin formation, and then followed by fibrinolysis. So in the anticoagulant, depending on the stage, there are various anticoagulants. First, there is a anticoagulant which act parenterally. So anticoagulants is name given to those drugs which affect the coagulation factors or fibrin phase of thrombus formation. So anticoagulants are parenteral and oral. In the parenteral and oral, in both, they are indirectly acting and directly acting. So indirectly acting parenteral include the heparin, which is the most common. Then low molecular weight heparin, which is a fraction of the heparin. We are going to learn why there is a fraction of the heparin. And then there is a fondaparinux and danaperoid, which also act similar to heparin. Then there is a directly acting thrombin inhibitor, which directly act and inhibit the thrombin, which include lepirudin, bivalirudin, and ergotraban. Now this was the parenteral. Then in the oral, there is warfarin, and then there is directly acting factor 10 inhibitor, name ends with exaban, like apixaban, and like that. So rivaroxaban, apixaban, these are factor 10 inhibitors. So name itself suggests 10 inhibitor, exaban. Then there is also direct thrombin inhibitor, which is called dabigatran. And these are the anticoagulants which act on the fibrin phase. Apart from that, we are also going to learn in the next lecture about antiplatelet, which act on platelet phase, and then also going to learn about the fibrinolytic, which acts in the fibrinolytic phase. So let's go with the anticoagulant. First, parenteral anticoagulant and the most commonly used drug, heparin. The name is also called unfraction heparin, UFH. Unfraction heparin because this is the whole heparin. So how it acts? It basically heparin. So this is the heparin. This is the heparin. It is a very large molecule, as you can see, and it has a very large tail. It combines with something called antithrombin 3. It combines with something called antithrombin 3. And this combination, heparin plus antithrombin combination, which is a very large, it can target both, either factor 2 or factor 10, because factor 10 is very large in size, but because it is a very large molecule, it can affect both factor 2 and factor 10. So that is the mechanism of heparin. It is a large molecule combined with antithrombin 3 and target thrombin as well as factor 2. So thrombin is factor 10 and factor 2. So bind with the antithrombin and inhibit both factor 2A and 10A. The most common adverse drug reaction is bleeding. Now bleeding, as you can easily think, because it is drug which is preventing coagulation, so bleeding should be very common. And those which are susceptible to bleeding, in them it is either used cautiously or not used, like there is a bleeding peptic ulcer or very recent surgery is there and still the stitches is there. So in those cases it should not be used. Now apart from bleeding, one important side effect is HIT, or called heparin induced thrombocytopenia. Why? Because apart from this anticoagulant effect, heparin also affects the platelet. It decreases the amount of platelet. It has antiplatelet effect, as well as it has something which promotes the platelet apoptosis. The amount of platelet decreases, which lead to heparin induced thrombocytopenia. Thrombocytopenia means decrease in platelet. Heparin induced thrombocytopenia. And there are two types. There is type 1, which is occur within 24 hours, around 24 to 36 hours, and it is self-limiting. It is only transient. So if it is transient, it occurs immediately, then we have to just wait and watch. It will improve automatically because it is self-limiting. But it is delayed after 2 to 3 days. It is delayed. Then it can be due to type 2. And in case of type 2, we have to immediately discontinue the heparin. Not only we have to discontinue the heparin, we can give the heparin antidote which is called protamine sulfate. Now, what is heparin? Heparin is a very large molecule and it is positively charged molecule. So problem is because it is a very large and positively charged, its bioavailability is not predictable and we have to constantly monitor it because we cannot predict that in this person this much response is going to be there. It varies from person to person. Protamine sulfate is a very highly charged negative ion. Heparin was positive, protamine sulfate is negative. So inside the body it immediately binds with the heparin and utilizes the heparin. So that is how protamine sulfate acts. So these are the side effects of the heparin. So uses of heparin, all the venous thrombus formation, like if patient has having varicose vein, then there can be problem of deep vein thrombosis. Then there is a pulmonary embolism. Pulmonary embolism has become important problem in case of the COVID. And apart from that, in case of angina and myocardial infarction also, heparin can be used. And recently, a very common use which you must remember is in case of treatment of COVID. Because in COVID there is something called D dimer which is increased, as if you have heard. D dimer is raised and it is a marker of increased chances of coagulation. So in that case, heparin is started, so coagulation can be prevented. So COVID is important indication of heparin. Now, problem with heparin is that response is unpredictable because it is a very large molecule, it is a charged molecule, and it also has a plasma protein binding. So its bioavailability is not predictable, and because of that, a regular monitoring is required. Apart from that, in the long term, it depletes the calcium and lead to osteoporosis. It also has some anti-inflammatory effect, but it also lead to heparin-induced thrombocytopenia, which we have seen heat. In type 1, no problem, but in type 2, very severe thrombocytopenia occurs and severe bleeding can occur. And it is hard to control. So, heat is a very big problem in case of heparin. So, these are the problem with the normal unfractioned heparin, out of which this first two problem, unpredictable response and regular monitoring. The problem is regular monitoring required with the laboratory measures. In the PHC, CHC, in the periphery, those type of availability is not there, and there occurs a problem with the monitoring. Sometimes the heparin giving heparin is become very difficult. So what to do? So we come up with the solution by low molecular weight heparin. Low molecular weight heparin. What is low molecular weight heparin? Basically, if you can see, this is the heparin molecule. We cut it from here. We make the fraction of heparin, so it become a low molecular weight heparin. Name English parin, enoxaparin, dalteparin, parmeparin. So parin, enoxaparin was become a very commonly used drug during COVID for the pulmonary embolism. So it is just a fraction of heparin. What happens that it can still bind and inactivate the factor 2, but because this long tail is not there, factor 10 can still be inhibited, but factor 2, that means thrombin, cannot be inhibited. So factor 10, it is still effective, but on the thrombin it is not effective. So that is the difference, but it doesn't make any difference because ultimately we are inhibiting the common path, because factor 10 is a common between both the intrinsic and extrinsic path of the coagulation. So we are ultimately inhibiting both the pathway, and we are inhibiting the thrombosis. So effect is similar to that of heparin. effect is similar to the heparin. So that is the low molecular heparin. Now, advantage of low molecular heparin: response is quite predictable, and we do not require regular laboratory monitoring. We can give upon weight to weight basis, and we can rely that patient will be have a predictable response. So regular monitoring not required, and that is why it can be given in the periphery where facility of the monitoring is not there. There is less chance of heparin-induced thrombocytopenia and long-term osteoporosis. Remember, the anticoagulation therapy which has been started in the post-MI patient, in angina patient, in patient of deep vein thrombosis, sometimes it remains for a lifelong. So we have to consider the long-term complications. So here long-term complication of osteoporosis is also not there. Chances of it is also very less. So it is very convenient. The problem is the heparin antidote, protamine sulfate, can only partially reverse the effect, and the cost is high. So that is the important consideration in developing country. Otherwise, it is very good. Most of the places it has replaced the heparin. Now, low molecular heparin is only used. Heparin is only used when low molecular heparin is not available. Now, other heparinoid, fondaparinux and danaparoid, they are longer acting, and they are alternative to heparin when heparin cannot be employed either due to allergic reaction or it has occurred previously. In that case, fondaparinux or danaparoids are used. Their mechanism is also similar. They bind with the antithrombin 3 and inactivate the factor 10A. So mechanism remains the same, and they are good alternative parenterally used drug. Now, direct thrombin inhibitor. So as we see that heparin, after binding to antithrombin 3, and then antithrombin 3 ultimately inhibits factor 10 as well as the thrombin. So this direct thrombin inhibitor, as the name says, they directly binds and inhibit the thrombin. So it is called direct thrombin inhibitor. It does not need to bind with the antithrombin 3. They themselves can inhibit the thrombin. The drug include lepirudin, bivalirudin and ergotabran. Bivalirudin is very rapidly acting. Again, it is useful as an alternative to heparin when the rapid action is required. Ergotabran, now low molecular weight heparin, fondaparinux, danaparoid, heparin, all are excreted unchanged in the urine. So when there is a problem with the kidney, they are all become unreliable because we cannot give it to the patient. So in case of moderate to severe renal damage also, ergotabran can be given because majority of the ergotabran is eliminated by liver. So that is the advantage of ergotabran. So it is heparin alternative in patient of the renal disease. Now, oral anticoagulant. So oral anticoagulant includes warfarin and direct thrombin inhibitors, which can be given by oral route, and direct factor 10 inhibitor as well. Oral factor 10 inhibitor. So these are the available drug to be given by oral route. Warfarin. Now, important thing to remember about warfarin that it takes up to 4 days for its full effect, and dose need to be monitored because again it has a very low therapeutic index. It is highly plasma protein bound, and many drug has interaction with the warfarin. Either they inhibit the metabolism or they replace the warfarin from the plasma protein binding site. And any increase in the warfarin little over 2 times, it can lead to severe bleeding. So close monitoring of the warfarin is required by international normalized ratio. So how international normalized ratio is measured? It is a prothrombin time which is compared against the normalized prothrombin time of the population, which is called international normalized ratio, and it is to be kept either 2 to 2.4 or 3 to 3.5 depending on the for the which indication we are using it. Here is the mechanism. Vitamin K which is important substance for the it is important substance for the synthesis of these all coagulation factor 7, 11, 10 and 2. For synthesis of all these coagulation factor, vitamin K is required. What basically warfarin do is, when warfarin go, it antagonize the effect of vitamin K. So this whole coagulation factor, their activation doesn't occur. But those which we have synthesized already are still in the circulation. So their level goes down slowly, then level goes down slowly. So over a period of time effect comes. So it takes about 96 hours or roughly 4 days for full effect of the warfarin. Remember that. Now, adverse effect of the warfarin. First of all, bleeding. All the anticoagulant drug produces the bleeding, and whenever there is any bleeding tendency, like recent surgery or peptic ulcer or trauma, in this they are all not indicated or contraindicated, we can say. Then warfarin induced skin necrosis can occur. A severe skin necrosis occurs and drug reaction occurs due to warfarin. So these are two major problems. Other minor problems, as I said, drug-drug interaction is there and constant monitoring is required. It is contraindicated in the pregnancy because it is highly teratogenic, and when there is a risk of hemorrhage is higher than the benefit, it should not be, it is contraindicated, like in all the bleeding tendencies. Now, how to monitor apart from the INR? Any unusual bleeding which occurs in the nose or stool, extensive menstrual bleeding or bruising, all these are sign of warfarin overdose, and immediately dose should be adjusted. Now, if the overdose has occurred, how to treat the overdose? We can give fresh frozen plasma, as we have just talked in the first slide. A fresh frozen plasma can be given, or vitamin K can be given. Fresh frozen plasma is immediately acting. This is very rapid acting, but it is short lasting. So if there is acute overdose is there, it is preferred. But over a longer period of time, vitamin K can be reversed. And if we want to restart the warfarin therapy, then it should not be preferred because it will take longer time to effect to come, and it has many drug-drug interactions, so it should be considered before giving that. Other oral direct factor 10A inhibitor. The name itself suggests exaban, rivaroxaban, apixaban, so it is exaban, factor 10A antagonist. So exaban is itself in the name. Now, use is I think not easily available. They are all used in the same as heparin, like deep vein thrombosis there, artificial heart valve is there, because artificial heart valve it is a foreign substance, thrombosis is very common, so we have to lifelong give the this type of anticoagulant therapy to prevent the thrombus. Apart from that, post-MI patient where there is chances of embolism is there, in case of deep vein thrombosis or in the pulmonary embolism, these drugs are preferred. So this was all about today's lecture. Have a nice day. Thank you.